And thank you very much to Shoppers Drug Mart, without which we wouldn't have an event, so that's fabulous. So the goal of today is a little bit different, and I'm very excited. I've been a founding member since the get-go, and we've been working towards this day. This is our very first chance to take the money that we've collected from all of our generous donors and do something exciting with it. So we've been working closely with the hospitals and the research departments to figure out how to do this. And as Marg mentioned, we chose topics, areas, and we did choose across the various institutions that we have for that, in order so that we could really spread it across the whole community. But we also decided to choose areas that we felt would speak to our whole group. And we really have chosen 3 areas that I would bet my bottom dollar all 3 of them have touched all of you in this room. So it's not going to be an easy decision, and I think after we hear from the experts about what you know, sort of depth of research that's happening in those areas in just our community, it's not going to be an easy decision, but I leave that with you in your cards. And we'll talk about the process at the end. Dr. Dealey is going to walk us through the process at the end. So you really have an opportunity to hear lots of details. Our first speaker is Dr. Shawna Johnston on our first topic. She's currently a full-time associate professor and attending staff member in the Department of Obstetrics and Gynecology at Queen's University, and is the current head of its division of urogynecology and reconstructive pelvic surgery. In her spare time, she also serves on the board of the University Hospital Kingston Foundation, so we're very happy that she's part of this group today. And then in the spare time from that, she takes care of 3 children. And she is here to present our very first area to consider, which is mental and fetal health. So Dr. Johnston?
Speak to you about an area in which I work on a daily basis, maternal and fetal health. Okay. I am a gynecologist and an obstetrician, and I work in the Department of Obstetrics and Gynecology. And my area of both clinical practice and research is in urogynecology and reconstructive pelvic surgery. So this is not my research area, but I work and have the privilege of working with people who are experts in the field of maternal fetal medicine and are doing really groundbreaking research on this topic. And so I'd like to present what they are doing, and I will be their advocate and their supporter, and I certainly am their fan because they're doing wonderful work. So the focus of the first bit of research that's going on in our department is that of cardiovascular health. And just to set the stage, women's cardiovascular health is a key national priority that should be addressed by improving cardiovascular awareness and prevention. I think you've all seen commercials on TV talking about women needing to understand that cardiovascular disease is the #1 killer of women across all age groups, particularly as women get older. And the key management approach for cardiovascular disease is actually prevention. And there are care inequities for women in general, so not all socioeconomic classes receive the same information about the education of cardiovascular disease and the education of risk factors. And that is also true of younger women. So perhaps younger women think they're somewhat immune to cardiovascular disease and don't become educated about risk factors and lifestyle modification. Or perhaps we haven't developed good educational strategies to educate young women. Preeclampsia, which is a disease of pregnancy, is an example of a marker of the presence of cardiovascular risk factors, and that's groundbreaking research. I think in the past, everybody has thought that obstetrics is a unique world on its own, and the diseases of obstetrics, the diseases of pregnancy, end when pregnancy ends. But actually, with emerging research done by my colleague, Dr. Smith, we're understanding that preeclampsia is actually a precursor or a marker of what is to come. Women, at least some women who develop preeclampsia, are actually heralding or unmasking themselves as women who in the future will develop cardiovascular disease. And in addition, because preeclampsia is associated with hypertension or high blood pressure, preeclampsia can also be viewed as a potential contributing factor to the development of future cardiovascular disease. So in some ways, preeclampsia is emerging as a marker, and in other ways, it's emerging as a risk factor for the development of cardiovascular disease in the future. And what we know now from early research is that early identification and treatment of cardiovascular risk factors can prevent long-term cardiovascular disease, which is exactly what we're supposed to be aiming for. And this is Dr. Smith, who is a MD, PhD researcher in my department, has shown is that a number of different risk factors increase your risk of cardiovascular disease. And you'll see them here. So he's identified that some of these factors can be identified early on in pregnancy by things like fasting glucose, and they can be used as markers for later cardiovascular disease. This is the data that looks particularly at preeclampsia. PENET is a research framework that Dr. Smith has developed, and that is Preeclampsia Network. So that's a registry of all women who developed preeclampsia. And what his early data shows is that if you develop, I'm just going to use my finger rather than a laser pointer, if compared to controls, which are the lowest bar on the left, if you develop preeclampsia, then your lifetime risk of cardiovascular disease is increased. And so if you look at from one extreme to the other, if you look in a controlled environment, at the very end, what Dr. Smith's early research has shown is that if you've never had preeclampsia compared to if you have had preeclampsia, your risk of cardiovascular disease is significantly increased. So that proves that there is this window of opportunity. That window of opportunity is called pregnancy, to look at women and say, what is your lifetime going to be like beyond pregnancy? That's very exciting research, and for the first time we have a chance to potentially make a difference in the long-term health of women based on what happens in their pregnancy. So he has expanded this preeclampsia network into a whole program, which is called the Mothers Program, and that's a euphemism for Mothers Health Education, Research, and Screening. And this is a collaborative effort with multiple researchers involving 2 other universities as well, that's trying to identify other risk factors beyond preeclampsia that could predict long-term cardiovascular disease. So this is very exciting research, and it involves a collaboration with researchers and clinicians in our department, Dr. Smith and some of his workers as well, and then there's the basic scientists who are participating in this research from Queen's University. And then Queen's University, other PhDs from other departments are participating, and then there's also collaboration with the University of Ottawa and with the University of Toronto. So this is a big and exciting project, and hopefully in the future we'll have data to show that there are things that happen in pregnancy that can be used to impact on a woman's long-term health, which is very important. The second focus is that of obesity. And this data, I shouldn't talk about this when everybody's eating, but hopefully it's not fair. Obesity has become an epidemic, and particularly in younger women. This data shows that in Canadian women who are entering pregnancy, many of them are in the obese or overweight class. So 44% of women, that's the yellow bar, are entering pregnancy at normal weight. Only 3% are underweight, and sorry to say, but the remaining percentiles are either overweight or obese entering pregnancy. And remember, these are young women. We just spent a minute talking about cardiovascular disease and risk factors, and using things like preeclampsia to potentially predict their patients' long-term risk of cardiovascular disease. But obesity at an early age predicts a lifetime of morbidity related to a bunch of diseases, including cardiovascular disease. So if the focus is on obesity and how we can improve women's long-term health by understanding and better addressing obesity at this early point in a woman's life, which is pregnancy, there is research going on in the department looking at maternal fitness and well-being. If we're going to try and encourage women at a young age to lose weight, we have to have research into what are the best tools to help them lose weight, and is it safe to recommend strategies to help them lose weight. And this is very elegant research done by another one of my colleagues, Dr. Greg Davies, who I have the privilege of working for. And this research, working with, not for, he might like to think it's working for. This research is ongoing, but the research to date has already demonstrated that mild exercise is safe in pregnancy. Many women assume that it is not safe to exercise in pregnancy, and instead of doing something positive for their long-term life and to prevent long-term weight gain, they stop exercising in pregnancy, and that begins a cycle of not introducing exercise into a lifestyle pattern even after pregnancy. We also know from Dr. Davies' research that moderate exercise is safe in pregnancy, and strength training is safe in pregnancy. And that, interestingly, in collaboration with Dr. Smith, exercise may actually reduce the risk of preeclampsia. Remember, preeclampsia is a risk factor for cardiovascular disease. So that's true collaboration at work, when you can marry one positive research finding with another. And that fit women have a better labor experience, and fit women have shorter labors. So all of this is valuable research that can be used on a day-to-day basis in clinical practice to tell people that it is safe to use exercise as a weight maintenance or weight loss strategy. Ongoing research in this area includes population-based randomized trials to really look at what the benefits of exercise in pregnancy are. We know fitter women have better labors, but are there other benefits from research? And those are larger studies that Dr. Davies is conducting now. Exercise-specific outcomes, so looking at, are there better forms of exercise in pregnancy to achieve certain outcomes than others? In other words, is weight training particularly good for labor, or is cardiovascular fitness, so distance running, better in pregnancy? And the impact of exercise on disease risk. We talked about preeclampsia, but there may be other benefits of exercise in pregnancy that confer long-term health benefit. And finally, we really have no data, and Dr. Davies is beginning to look at exercising elite athletes, because we really don't know if Olympic level athletes can continue to exercise in pregnancy and how that will affect their outcomes. The other focus of research in our department, and this is more than just our Dr. Davies, there are other researchers in our department interested in smoking cessation. We all know nicotine is a dangerous drug. There are 1,000 reasons why nicotine is a dangerous drug, and it's particularly dangerous in pregnancy. 20% of women in Kingston entering pregnancy smoke. That's a pretty disappointing statistic, knowing all that we know, even considering that the cigarette boxes have "do not smoke in pregnancy" on them. And we really don't have very good data to talk about smoking cessation techniques. In the whole world literature, there are only 5 studies on the safety and efficacy of nicotine replacement therapy, nicotine patches in pregnancy, and 1 study on Zyban, which is another sort of popular strategy. So we need more data on how to get women in pregnancy to stop smoking for their long-term health benefit. Pardon? Oh, sorry. And there's no studies on Champix. So we really need more data in this area, and this is becoming an important focus of research, because we're leaving pregnant women behind in the battle to stop smoking, and that is clearly affecting their long-term health. And then finally, a final area of research focus in our department is that on preterm labor. Preterm labor affects about 8% of pregnancies in Kingston. And those preterm labors are costly to the system, they're costly to patients, and they confer long-term morbidity to the infants who deliver preterm. We know from research, again done by Dr. Davies, that transvaginal ultrasound scanning can predict some preterm labor. Vaginal progesterone, which is a hormone that can be inserted vaginally, can actually now prevent some preterm labor. So it's of value to predict who's at risk for preterm labor. But we still need to understand who to do transvaginal ultrasound on and who to use vaginal progesterone on. This is the beginning of research in this area, and we need to understand better how to identify people at high risk for this disease, which is preterm labor, and therefore how to prevent it. And what these 2 pictures show are the use of ultrasound as the screening tool for women at preterm labor. What you can see in this picture is an ultrasound of a normal cervix. And I don't know how well it projects in this room, but there's a little marker here and the little marker here. And that's a normal closed cervix in pregnancy that's about 4 to 5 centimeters long. This is the opposite. This is a woman who's got a widely open cervix. It's again about 4 centimeters long, but it's not closed, it's open. It's just closed at the very end, and what you see here is a distal 0.5 centimeter. So instead of having a long closed cervix that will help maintain a pregnancy, this is a woman at 20 weeks. This is a woman at high risk for preterm labor because her cervix is already thinned to more than 90% of its thickness, and it's starting to open up. So if we can identify women, ideally before this happens, and use things like vaginal progesterone, if we understand that better, we can stop preterm labor. And then this is some of the other research, just to show you some interesting pictures. This is using advanced imaging techniques, what's called fetal MRI. So you can do an MRI of a fetus, and you can get these astonishingly beautiful pictures. And this is just an image to show you, here is what looks like a normal baby. I've always thought this almost looks like an invasion of privacy to see this much detail in utero on a baby. This looks like a normal baby, but this is a baby on ultrasound who has a serious structural cardiac defect that is actually not compatible with life unless that baby has urgent heart surgery within the first few days of life. So knowing this meant that this baby went to Toronto and delivered in Toronto and had cardiac surgery within 24 hours, and this baby survived. So that's the value of research. And here is another baby. Using 3D ultrasound, we can identify a cleft lip. Now that may not be a lethal anomaly. I think you can see it from back in the room, and the eyes are here, nose, and you can see this defect. But cleft lips and cleft palates are associated with other structural anomalies. So this is the same baby, and when we look, we see hydrocephalus, which is excess fluid in the brain. And this is actually a baby who needed a shunt, again, early in the postpartum period, right after delivery, in order to preserve brain structures. So knowing these things can make a difference in fetal health. Knowing these things can make a difference in delivery route sometimes, and knowing these things can make a difference sometimes in where patients deliver to get the most expeditious care. So that's just a highlight of some of the things that are going on in my department, and I hope that I've managed to convince you that there are benefits to mothers and babies by doing this kind of research that are long-term. Thanks.